Well, hello everyone, and welcome to our CASE conference webinar via the Academy of Consultation-Liaison Psychiatry. I'm Dr. David Fipps. I'm a CL and addiction psychiatrist at Mayo Clinic, and I'll be moderating this event and introducing our speakers. And as a reminder, this is one of many of our monthly series of alternating CASE conferences, educational webinars, so be on the lookout for the upcoming events that we have. But today's 30 to 45-minute CASE conference representing the Women's Mental Health SIG will include a brief case presentation by a trainee, followed by a facilitated case discussion with a CL faculty member, and then end with a Q&A session. So if you have questions, please put them into the Q&A option. Feel free to use the chat for comments, but we will only be answering questions inputted into the Q&A option. Our trainee presenter today is Dr. Stephanie Fagbemi. She is a PGY4 resident at Brigham and Women's Hospital. And our faculty discussant today is Dr. Vanessa Lauzon. She is an associate clinical professor of psychiatry at UC San Diego School of Medicine. And without further ado, I'll hand it over to Dr. Fagbemi for her presentation.
Thank you, Dr. Fipps. So I will get us started with the presentation. The title of today's presentation is called SSRIs in Pregnancy, the Risk versus Risk Conversation. I would like to first get started by making these acknowledgements. Dr. Tessler, my faculty mentor at the Brigham, Dr. Lauzon, who's our faculty discussant, Dr. Fipps, obviously our host, Ryan Sardenis, Diego Nolasco, Dr. Robin Zahal, and Dakota Carter, who also helped us put this together. So I'll get started with the case. The chief complaint is of a woman who is 37 years old, G2P1, meaning that she is on her second pregnancy, has already had a child. She's a Black woman, 9 weeks gestation, with a past psychiatric history of generalized anxiety disorder and postpartum depression and OCD, who arrived to the Women's Mental Health Clinic wanting to discuss management of her sertraline in pregnancy and establish care with us in women's mental health, given the complex psychiatric course with her first pregnancy. Here's kind of a timeline of events that led up to her presentation with me. Immediately postpartum, she felt a sense of immense sadness and failure. She felt that she had failed due to having had an unplanned C-section. She noticed that she was having obsessional worry, repeatedly checking if her baby was breathing. At 2 months postpartum, she noticed intrusive harm thoughts. These were ego-dystonic thoughts of throwing her baby down the stairs or drowning him in the bath. At this point, she started on sertraline 25 milligrams. At 3 months postpartum, compulsions emerged. She avoided carrying the baby on the stairs or bathing him. A difficulty sleeping had also developed at this time. At 4 months, she lost her support system. She relocated away from her family and her support network, and she then increased her sertraline to 75 milligrams. At 6 months postpartum, her best response to her sertraline was identified at 125 milligrams being the most helpful. And then she came to see me at about 3 years postpartum. She was taking 50 milligrams daily, reduced from her previous dose of 125 milligrams. Some more on her past history. She's presenting now to our clinic at 3 months postpartum, wanting to know if she should make any medication changes, trying to be proactive in advance of her second baby. She currently feels as though her mood, her anxiety, and her OCD are well managed at this reduced dose of 50 milligrams. She has been stabilized at this dose and has been medication compliant. She is well connected right now with an outpatient psychiatrist and psychologist who both specialize in women's mental health and are Black women, but both will be out of network. She's decided to transition her care to an in-network psychiatrist, and this is her first visit with me, and she was pleasantly surprised to find that I was also a Black psychiatrist. Some more history. Generalized anxiety disorder, postpartum depression, and OCD. No history of self-harm attempts or suicide attempts. Medication trials were sertraline up to 150 milligrams and trazodone 50 milligrams. No psychiatric hospitalizations. And she has been working pretty consistently with a psychologist and psychiatrist since her postpartum diagnoses. Her past medical history includes asthma requiring an inhaler and gestational thrombocytopenia in her previous pregnancy. No other relevant medical history. Past surgical history is relevant for an emergency section in her last pregnancy. And family psychiatric history includes a mother with major depressive disorder and a sister with generalized anxiety disorder. Her social history. She's currently living in a house with her son, who's now 3 years old, and her husband. She has a PhD in the social sciences, is currently a college professor, married to her husband. Her childhood was notable for having a good childhood, but an abusive mom. Her parents were divorced, had a sister and a brother. Mental status exam was relevant for being appropriately dressed, cooperative, good eye contact, pleasant, well-related. Her mood at the time, I asked her in the context of her cognitive exam, was annoyed and then amused. Affect was mood congruent, euthymic, full range. Notable labs include that she had a platelet count of 230 about 7 months before our visit. But prior to that, the value at its lowest 3 years ago before during her pregnancy was 167. So through this clinical presentation, I had some guiding questions. What are the risks of harm to the patient and baby by keeping her on an SSRI? What are the risks of stopping the SSRI? And would it make sense to try a different medication? And with that, I'll pass it on to our Dr. Vanessa Lauzon, our faculty discussant.
Thank you so much, Dr. Fagbemi. And it's very important that Dr. Fagbemi has framed this as a risk versus risk discussion. We are comparing the risks of medication exposure versus the risks of untreated or undertreated maternal mental illness and pregnancy. All people are susceptible to omission bias, which is a type of cognitive bias that even affects physicians and their patients, where we tend to give more weight to the risks of doing something versus to the risks of not doing something, such as prescribing or taking a medication versus leaving symptoms untreated. And so it's really important for us to have balanced risk discussions in order to make evidence-based choices about care. And so with that, we're going to talk about 3 risks associated with SSRI exposure in pregnancy that we counsel about, and we're going to talk about the risks of untreated maternal mental illness. The first risk that we're going to talk about is neonatal adaptation syndrome. And this has its onset within the first few days after birth. It is generally mild and self-limited and resolves within usually a few days, but up to 2 weeks. The symptoms can be a spectrum of severity and of how many symptoms the infant has, but is generally characterized by some irritability or tremors, perhaps some respiratory distress or tachypnea, and poor feeding or which can accompany hypoglycemia and temperature instability. The treatment is non-pharmacologic and is supportive in nature with frequent feedings, swaddling, and increased skin-to-skin contact. It's important that we put, for each of these, that we put the magnitude of the risk in perspective. And a large population-based cohort study of over 280,000 term infants found that the NAS rate of unexposed infants was about 4.4% as compared to 11.2% in SSRI exposed infants. And when we talk about that in terms of relative risk, that means that SSRI exposed infants are about 2.5 times as likely to experience NAS compared to unexposed infants. When we put that in more absolute terms, I kind of like to use sometimes a number needed to harm to help people understand magnitude. And so the number needed to harm would be 15, which means that you would have to expose 15 pregnancies to SSRIs to have 1 additional case of NAS, statistically speaking. The next risk that we talk about is persistent pulmonary hypertension of the newborn, which is abbreviated PPHN. And this represents a delay of the normal physiologic transition from the fetal circulation pattern to the postnatal circulation pattern. And so that right to left shunting that is normal in fetal life persists postnatally, and there's a delayed transition to the postnatal circulation pattern. So this is apparent immediately at birth, and when it's SSRI associated, is reversible within a few days. This presents as perhaps hypoxia due to the right to left shunting and labile oxygenation despite supplemental oxygen support, and in some cases, mechanical ventilation. And this, while it can be serious, and this is super important to talk about, the prevalence is very low, and this is a rare event. The sporadic rate of PPHN in unexposed infants is about 0.21%. I like to round that off to about 2 per 1,000. And then when we look at SSRI exposed infants at 0.29%, it's about 3 per 1,000. So putting it in these round numbers can make it easier for people to understand. And when we calculate a number needed to harm, that would mean that you would need to expose 1,000 pregnancies to SSRIs in order to have one additional case of PPHN in a newborn. Things that affect risk include obviously SSRI exposure, and it has been associated with SSRI exposure in the latter half of pregnancy. But more recent studies have actually found that among the serotonin reuptake inhibitors, sertraline may carry the lowest risk of PPHN when compared to other serotonin reuptake inhibitors. It's important that Dr. Fagbemi mentioned that this patient has a history of asthma because maternal asthma is an independent risk factor for PPHN, even without SSRI use. The third risk that we talk about and counsel patients about is bleeding risk or postpartum hemorrhage. And so the relative risk of postpartum hemorrhage with SSRI exposure is between 1.3 and 1.5 as compared to unexposed pregnancies. And there are two mechanisms by which SSRIs can confer increased bleeding risk. The first is through impaired platelet aggregation, which many people will be familiar with from previous discussions and previous webinars that we've had about the effect of SSRIs on bleeding. The second pathway or mechanism is that SSRIs actually can affect uterine contractility. And so the impaired uterine contractility can result in a failure to clamp down on those blood vessels immediately after delivery and reduce bleeding. This is generally managed through routine obstetric monitoring and routine obstetric procedures, such as administration of a uterotonic agent immediately after delivery. When we look at the magnitude of this, a very good study looked at the average difference in blood loss in spontaneous vaginal deliveries between SSRI exposed versus unexposed pregnancies, and found that the difference in blood loss was less than 100 milliliters on average. That is, in terms of blood loss, a relatively small amount. The patient in the case had a history of gestational thrombocytopenia, and gestational thrombocytopenia is independently associated with bleeding risk as well. Now, in terms of the combination of a person with a history of gestational thrombocytopenia and taking an SSRI, this hasn't been well studied in large systematic studies like prospective cohort studies. But we do know that both of these factors can increase bleeding risk. And so these are important factors to talk about with the patient. So we've covered three main risks of SSRI exposure in pregnancy that we counsel a patient about. It is equally important for us to talk about the risks of untreated maternal mental health symptoms. And in this situation, we're talking about perinatal mood and anxiety disorders, right? This is a patient who experienced depression and obsessive compulsive symptoms on a background of generalized anxiety disorder. So untreated maternal depression is associated with an increased risk of preterm birth, as well as intrauterine growth restriction and low birth weight. Postnatally, maternal depression is associated with reduced breastfeeding initiation, success, and duration, which is, of course, really important for both maternal and child health. Untreated maternal depression also impacts maternal-infant bonding. And in this case, we also need to think about, she has a 3-year-old son, and so untreated parental depression also affects parenting of not just infants, but older children as well. Untreated maternal depression is also associated with poorer language, cognitive, and motor development in the first 2 years of life, and is associated with children receiving fewer preventive health services. This is all in addition to what we know about the psychiatric risks of untreated depression and the potential for untreated obsessive compulsive disorder, which this patient has experienced. We know that there is a maternal mortality crisis in this country, and that mental health, including suicide, is unfortunately a leading cause of maternal mortality. And so untreated depression obviously increases suicide risk. And then additionally, we have to think about the impact of untreated symptoms on her occupational functioning and her social functioning, including relationships with partner and other important supportive adults in her life who form part of that social support network to help her be healthy, well-rounded, and the best possible parent. And finally, we need to also consider the racial and equity context of this. In this country, Black infant mortality is more than double the infant mortality of white infants. And maternal mortality rates by race mirror that. Black maternal mortality is significantly higher than for non-Hispanic white women. And as you can see in the figure on the left-hand side of this slide, that gap actually increased between the years 2018 and 2021. And there's good evidence that when Black patients receive care from Black physicians, there's a substantial reduction in that racial mortality disparity. And this patient that was presented was aware of that and actually was seeking out Black physicians and therapists in order to be attentive to that impact on her care and to advocate for herself in order to have the best possible and most equitable care. With that, I'm going to stop sharing, and I will turn this back over to Dr. Fagbemi to provide us an update on the case.
Thank you, Dr. Lauzon. So I would like to share a bit of a case update regarding this patient. So today, she is currently in her 3rd trimester. We ultimately decided not to change her medications during the pregnancy, at least at this point. But we have scheduled up until this point and beyond weekly or Q4 to 6 weekly check-ins to see if she needs to increase or change her dose as needed. Her mood, her sleep, and intrusive thoughts have all been good or manageable with this dose of sertraline 50 milligrams. And she has decided to schedule a C-section for baby number 2. I'd like to now pass it on to Dr. Fipps.
Excellent. Excellent. Thank you so much for a great presentation and a good discussion as well. Audience members, we are now transitioning to the Q&A session of this, so please use the Q&A format and option of Zoom to put in your questions. Feel free to use the chat for discussion, but we're only answering questions from Q&A. And a few questions here that we have already, specifically. A very common question that comes up is regarding dosing changes that may need to occur around pregnancy, especially when we're talking about trying to avoid or address some of the risk parameters. How do we address concerns and or the process of dosing, if any, when an individual is going through their pregnancy?
Thanks so much for that question. It is one of the most common questions that comes up. And so the 2 parts of that often come up is, does a dose reduction protect or reduce the risk of NAS or PPHN? And the answer appears to be no. And so I would not preemptively recommend a dose decrease. There was a 2010 register study that found that SSRI discontinuation in late 3rd trimester did not have a significant clinical effect on improving neonatal health outcomes, including respiratory distress, after controlling well for maternal illness severity. And then we have to consider that reducing or interrupting effective SSRI therapy can increase the psychiatric risks for the pregnant person. And we do not at this point have large-scale systematic data to inform us about whether risks are dose dependent. And so without clear evidence of a benefit to reducing that dose, and knowing that by doing so, we actually put a pregnant person at risk of symptom worsening or recurrence at a very vulnerable time, we do not preemptively recommend dose reduction. Sometimes doses need to be increased during pregnancy. There are predictable pharmacokinetic changes that happen during pregnancy, and many people will find that their previously effective dose of medication becomes less effective sometime in the late second trimester or the third trimester. And so this is a time when I'm trying to schedule frequent check-ins with people and give them preemptive counseling about that so that they know to contact me if they're finding that their medication is less effective than before, and we can plan on doing a dose increase if that happens.
That's a great point and a very common question that gets asked. And kind of from that same vein, you mentioned doses need to be commonly increased during pregnancy. And we know, especially with obsessive compulsive disorder or obsessional thinking, sometimes people find benefit from supra therapeutic dosing, even above what is commonly recommended, or at least by the book recommended for some of these patients. How would you approach either one of the contexts where someone's already kind of at the generally considered max dose, and you mentioned sometimes you may feel the need to increase, as well as just like OCD dosing, which is typically above what is commonly considered the high dose in someone who has pregnancy?
Thanks for that question. So the most important thing is effectiveness. And so we should use an effective dose that treats symptoms. You are right that, of course, in OCD, we often need to use doses that are higher than generally published FDA ranges. And if that is the dose that is necessary in order to effectively treat her OCD symptoms, then that is what we should do. And as I just mentioned, because of pharmacokinetic changes in pregnancy that tend to lower drug levels for most drugs in pregnancy, even a person who was perhaps on 200 milligrams of sertraline pre-pregnancy, if that's what was controlling her well, might need to go to 250 or 300 in pregnancy, so long as she's tolerating that and it's effectively treating symptoms.
Very good. Very good. Excellent. And you mentioned this risk and risk conversation very much from the lens of how we discuss it with patients. We have a few questions that pertain to how we approach these conversations with OBGYNs specifically. Do they ever have counseling? Do they similarly be well aware of some of this data to where they counsel the patients? Are there opportunities for us to better liaison with the OBGYNs? And how would we approach the risk conversation from a physician to physician standpoint rather than just physician to patient?
Thanks for that. I think we have substantial opportunities to improve our liaison at large with our OBGYN colleagues. And, if you've seen one health system, you've seen one health system. And so these relationships probably vary between people's institutions. It is very helpful that the American College of Obstetricians and Gynecologists has a practice bulletin and a clinical practice guideline that strongly supports continuing antidepressants in pregnancy, and that strongly supports not discontinuing or withholding antidepressant treatment on the basis of pregnancy or lactation status alone. And when I have liaison conversations with obstetricians and gynecologists, it can be really helpful to bring a colleague's own professional society guidelines to the conversation, in addition to the expertise that we provide to help bolster that conversation. A lot of us are quite fluent in statistics, but to varying degrees, depending on how much time we sort of spend, in the world of statistics. And again, some of the things that are very effective for patient conversations in terms of magnitude of risk, actually, I find end up being really helpful in clinician conversations. Bringing in things like absolute risk, number needed to harm, number needed to treat, can actually help put things in perspective in a way that's really meaningful.
Very nice. And in our language as well, even helps them better frame it instead of sometimes. I like it. I like it. And on the note of the risks, I know another, you mentioned the neonatal adaptation syndrome, persistent pulmonary hypertension newborn. But another one they come up with, as you mentioned, was also bleeding risk. Is there ever a point or certain comorbidities that the individual may have that would eventually say, you know what, the bleeding risk is too high to consider to continue forward with sertraline?
There's no absolute, cutoff. These are complex shared decisions that should ideally happen between the psychiatrist, the patient, and their obstetric provider. And it's really important, yes, for us to, how do I want to say, it's really important for us to help put those risks in perspective. And at the same time, it's very important that we respect the autonomy and agency of pregnant people, particularly people from marginalized identities. And showing respect for that autonomy and agency is actually an incredibly powerful way of building trust and improving outcomes. So we have that role in contextualizing data, but I don't think that we have a role in making absolute statements about when bleeding risk reaches X, I absolutely wouldn't do this, because each person's also sort of psychiatric risk and other medical risks are going to vary, and it really has to be individualized and ultimately something that the patient themselves is comfortable with.
That makes sense. And it's kind of from that same context, does the bleeding risk impact the team's recommendation of whether or not they want to consider a vaginal birth versus a C-section, for instance?
I'm going to answer this with the caveat that I am not an OBGYN. However, current obstetric guidelines actually say that the mode of delivery should be determined by other routine obstetric indications rather than by maternal bleeding risk alone. So even being on an SSRI or having a history of gestational thrombocytopenia, for example, does not dictate what the appropriate mode of delivery is. But some things that I might consider in that conversation, again, with my patient and with her OB, would be, for example, like how much risk is she comfortable tolerating? I think location of delivery is an important discussion, ensuring that a delivery with an elevated bleeding risk is happening in a setting where there is sufficient medical staff available to help manage that safely. And then also acknowledging, like in this case, the patient had an unplanned C-section, which was a source of distress for her. And we should actually acknowledge that obstetrically, the unplanned C-section after an unsuccessful trial of labor does carry a higher risk of significant bleeding as compared to vaginal delivery or, say, a planned C-section. And so if this patient is not able to sort of tolerate the risk of another emergent C-section or the risk of increased bleeding, then having that conversation about what would make a more controlled delivery experience could be a very patient-centered thing to do.
Makes a lot of sense. That's good. That was a good answer for that. And a few times we've seen some conversations about having an equality between a Black patient and a Black provider, especially. And I believe there's one that says, I see an increased risk of maternal and infant mortality in Black families in general. Is there an increased risk with side effects of SSRIs in Black mothers and babies? Are there other ways that we would recommend approaching this racial continuity, especially if there may not be access to individuals with similar race in the center? How would we approach some of these considerations, knowing some of that data?
I think there's some important considerations you bring up in that data, and there are some shortcomings of the data that we have. So our existing literature on SSRI safety in pregnancy doesn't stratify outcomes by maternal race or ethnicity. So we don't have sort of large meta-analyses or systematic reviews examining the SSRI-associated risks and stratifying those out by race. So I don't have data to say whether Black moms taking SSRIs have a different risk of, say, PPHN or NAS or low birth weight or preterm birth compared to say, white moms taking an SSRI. I think it's important for us to note that there are disparities in access to appropriate mental health care by race, and that there are race disparities in SSRI prescribing in pregnancy. I think the most recent data is actually that pregnant white women who are pregnant are actually like 3 times more likely to receive an SSRI prescription than Black women in pregnancy, and Black women are less likely to receive a referral onwards to treatment for depression in pregnancy. And we have to address those disparities as well. And so we certainly, need to address this issue of undertreating depression, and there being a disparity in the undertreatment of depression in pregnancy. And then, to the equity question and the sort of the racial and ethnic congruence or incongruence of the provider and the patient. I mean, it's all of, I would say that it is all of our responsibility to close this gap. And we really need to listen to our patients. We really need to foster that trusting relationship where they can bring all of their concerns to us, and we are tuned into their symptoms and their concerns. Because when we see bad outcomes happen, I think a lot of times when those cases are analyzed, what often gets brought to light by the patient is, I had these concerns, I felt something wasn't right in my body, I had these concerns and my concerns were not heard, my concerns were not addressed. And so that, I think, is a way that all of us can be working toward more equitable care that's really truly patient-centered.
It's an excellent way to wrap this up then. I appreciate that good, solid, concise answer there. Well, so I apologize to our audience. We weren't able to get to all the Q&A sessions, but I appreciate how active the audience was for this, and great presentation from our colleagues and panelists. I appreciate everyone's involvement in the webinar. As a reminder to everyone, if you missed it or want to see this again, this will be posted on a few of the different social media platforms of the Academy, the Twitter, the Facebook page, and the website. But until next time, glad to see you, and thank you all for coming.